It's time for another dental office review. As part of this series, I'm taking some time to go through dental office reviews, and I want to review this one. So here it is, obviously left by someone with some training, a PhD FNP. And what we want to do is just review this real quick. So Dr. So-and-so did some dental work on me that involved putting a permanent crown on one of my teeth. For this, I paid him whatever he asked me at the time of the appointment, as well as he got paid from my dental insurance. In over a year, this crown fell off. See attached picture down here. This happened because he did not do it right and because he's not a good dentist. I also had a conversation with him about dental implant work at the time, and every time I spoke with him, I was surprised with his lack of knowledge. I'm glad I didn't proceed with him for my implant work. Otherwise, it would have been the same mess. If he cannot put a simple crown where right, there's absolutely no way he can do implant work for other complicated work right. Yikes. So stay away from this dentist. He will charge you an enormous amount of money and will do the crappiest piece of work. Okay, let's talk about this. So nobody's perfect, all right? First, let's address the concern about the crown that came off. So periodically, we'll have a dental crown that comes off. It happens. Dental crowns are a prosthetic piece of ceramic or some hybrid material that's composite ceramic. There are different versions of ceramics, or they're a porcelain fused to metal crown, and they have an attachment, usually a resin bonded attachment to the tooth. However, not all teeth are created equal, just like not all crowns are created equal, and not all dental cements are created equal, and not all dental bonding situations are created equal. So there are a lot of variables. Now that's not meant to excuse a crown that's come off. But let's talk about the most common reason for a crown to come off, in my experience. Number one, that is moisture contamination during the bonding protocol. It's not as simple as just sticking some super glue inside the crown and sticking it on the tooth. Bonding is actually very technically complicated and requires a bunch of different chemicals and chemistry. So the first thing we have to do is prepare the tooth, and that requires, in most cases, a couple of different chemicals, sometimes 3 chemicals. There's an etchant, which is like an acid that actually microscopically prepares and softens the outer 20 to 50 microns of the tooth in preparation for the bonding. It's a conditioning agent. Then there's a priming agent, which allows the surface to be wet. And that's allows the chemistry to permeate into the dentin itself. And then the third chemical is actually the bonding resin. Now some adhesives come with all 3 of those chemicals together, but not all of them do. So with that in mind, sometimes it's difficult to get a perfect working field to prevent the chemistry from being contaminated by saliva or humidity. Now there are all sorts of things we can do. We can use suction, we can use cotton rolls, we can use what's called a rubber dam, which isolates the tooth and protects things. But even so, if you have a very humid day, or if the air conditioner isn't keeping up well with the humidity in the air, sometimes that'll inhibit or decrease bond strength. So prepare the tooth. We also have to prepare the crown or the prosthetic. Depending on the ceramic type, some ceramic types are more bondable, stickier chemically on the surface to various different dental cements. And so depending on what type of material you order, whether it's zirconia, lithium disilicate, lucite, feldspath, a hybrid ceramic, or some sort of a metal, alloy, we can have all sorts of different chemical bonding properties and strength ratings between the bonding characteristics between the ceramic and the cement. So we have the tooth, we have the ceramic, and then there's the cement that goes in between them that bonds the two to each other. The cement itself comes in different forms. There's a glass ionomer form, there's a resin modified glass ionomer, there's a standard resin cement, there's some luting, L-U-T-I-N-G, luting cements, which are like conventional cement. There are all sorts of different materials out there that we can choose from as a dentist. And sometimes we pick and choose the cement based on what's worked well in the past, what other dentists recommend, the highest strength ratings, and sometimes it's based on an individual situation. So it really depends on what's happening in the mouth at the time. So with regard to a crown coming off, it happens. Most common way is moisture contamination. We talked about complicated chemistry. The second most common reason that a crown will debond is because of sclerotic dentin. So dentin, the inner layer of the tooth, becomes sclerotic, meaning the chemistry inside the dentin changes ever so slightly as it's exposed to tooth decay or filling material or saliva. So as the tooth itself changes, it becomes less sticky from a chemical standpoint, as I mentioned before. All of the dental cements that we use in dentistry are based on kind of an assumed average or an assumed chemical composition of the dentin. And so it's not uncommon to find someone that has a variation from normal or from the most common, expected chemical composition. And in that situation, we may have to try a different cement. So I think in my experience, we see maybe 1 debond per 100 crowns. But when you're doing, as a dental office, 50 to 100 crowns a month, plus all the patients you've had in the past, we see a re-cement once a week or so. But it really just depends on the situations at hand. There are some dental offices, some states that allow dentists to delegate to dental assistants to bond a crown in. And in some situations, some of those assistants may not be as adept at bonding. And it's possible, it could be just a situation where the bond didn't do what it was supposed to do. There's a lot of reasons why a crown might be bonded. Okay, so let's talk a little bit more about the dental implant knowledge. So dental implants are the most complicated thing we do in dentistry. Because of all the different parts and pieces that are oftentimes involved in a dental implant. You have the surgery to place the implant, which many dentists don't do. Some of us have done a lot of it, but many dentists don't do. So they'll send out to an oral surgeon. That requires some, some consultation and communication, collaboration with the oral surgeon or the periodontist. After everything heals, then there's a restoration process. And a lot of the restoration process depends on the type of implant that's used when you're restoring the tooth. So there's Zimmer, there's Nobel Biocare, there's Implant Direct, there's Neodent, there's 100, probably more than 100 different dental implant manufacturers, and there are different platforms, different implant shapes and sizes within those platforms. So it can be a challenge to do, to restore. So with regard to that, it's possible this dentist didn't have a whole lot of experience with dental implant placement or restoration. Usually as dentists get further along in their career, they may see more experience with restoration or with placement, and we might get a lot more comfortable in dealing with this. I know personally I've placed a lot of implants and restored a lot. So when you run across a situation where it may be something where, explaining things, for a younger, less experienced dentist, there may be a perceived lack of knowledge, and it may just be related to a lack of experience dealing with the implant process. When we get to the point where we're talking about the full arch restorations, where you've got multiple implants and you've got a fixed bridge that's screwed in, the costs are $60,000 or $70,000 for one patient for a full mouth of implants. That's something that many general dentists don't do. They'll send to an oral surgeon or a prosthodontist, someone with a lot of advanced training. So let's see. Enormous amounts of money. In my previous video, I kind of talked about how each of us has a different concept of what dental care should cost. And so much of our dental care, as it relates to enormous amounts of money, is dictated by the insurance companies themselves. Some dentists, there's another review I was just reading, some dentists will opt out of insurance plans because those insurance plans either coerce a lower fee or they reimburse very poorly, or they're just difficult to work with. For some insurance plans, if I do a crown today, I won't get paid for it for 2 or 3 months. And that's only after we've appealed 3 times. And so sometimes those insurance companies, we just don't want to work with. It'd be like buying a vehicle from, an auto dealer and not being able to get in for service. It's just something that we shy away from as dentists. And as I mentioned before, most insurance companies are geared toward protecting the shareholder, not necessarily toward benefiting the patient. Although they realize to some extent there's a balance between benefiting the patient's health and increased shareholder benefit. So it's a balance. Okay. So let me just comment here on, the PhD FNP. And this isn't meant to be a commentary on this person, this gentleman. We as dentists don't have all the dental knowledge in the universe. There certainly is a lot of other knowledge out there. Personally, I don't think dentistry is something that, let me rephrase. I think most people could do dentistry just fine with the right amount of training and experience and didactic coursework. But oftentimes you'll do a Google search, a patient will do a Google search and come up with some answer from some social media or something that is really irrelevant in clinical practice. As I've mentioned in other videos, this is something, if we're talking about clinical success rates and long-term outcomes, it's something that we have to look at double-blind controlled studies that are peer-reviewed. If you don't have a peer-reviewed study that's controlled with a double-blind design, and there's not an absolute statistical significance in the outcome, then the data that you're looking at is not really relevant. What Mark Twain would say, there are three types of lies. There's lies, damned lies, and statistics. And so we have to be very cautious with how we look at things statistically, and also with the data that we're gleaning from an online resource. I mean, look at the artificial intelligence that we have now in context. The challenge many times that the AI, ChatGPT and the OpenAI has is they don't understand the context. And so like I mentioned, a patient will come to us with a frustration that says, crown came off, you're an idiot, but they may not realize the context of, we have a whole bunch of complicated chemistry. You were not willing to hold still, you wouldn't allow us to put the bite block in, you refused the rubber dam, you kept coughing, you kept moving around, your tongue was hard to control. There's more context there than most of us really look at. So context is absolutely critical when we're talking about long-term outcomes. So I think this is a good review to review. I think it's allowed us to gain some good information. I don't think I'm violating any rules. I've tried to block out the information that's identifying of the dentist and the patient. But this is something that this patient posted in a public forum. So if he becomes aware of it, I'm not meaning to talk in a derisive way about what you're saying. I think your concerns are relevant, but it's helpful to get the context from the other side of the story. And I don't have any of the dentist's context. This is just me thinking out loud. So hopefully this has been helpful. I'll continue to try to do one of these reviews periodically as I come across a review that I think warrants or merits additional light, at least light from a different perspective. So thanks.